Dear friends, dear ladies and gentlemen, it's our pleasure to present another case of the month. You see, we are in the middle of holiday season, winter holiday season, and we decided today to take rather a short and nice case to discuss it quickly with you, and then we need to go back to what you see in the background. So this is our small present to you. This is a nice case demonstrating a lot of things related to spondyloarthritis. As you see, this is a case of a 40-year-old male with a history of uveitis. In addition to the uveitis, there is a history of back pain, and that was at the end of the day a reason why the ophthalmologist decided to send a patient to a rheumatologist. There were in total 3 flares of acute anterior uveitis over the last 10 years, so it is not very frequently recurrent. And back pain started well before the first occurrence of uveitis. Back pain has inflammatory characteristics with slow onset, with improvement with exercise, no improvement with rest, sometimes also awakening because of pain in the night, and there was a history of morning stiffness, sometimes longer, sometimes shorter. NSAIDs, which a patient took from an orthopedist on demand, were quite helpful to control the symptoms, and that was probably also the reason why we see this patient now almost 20 years after the symptom onset. No other spondyloarthritis manifestations, no family history of SPA. At clinical examination, there was nothing really remarkable, a bit of tenderness over sacroiliac joints, but no relevant limitations in spinal mobility, no peripheral manifestations, and also no skin changes. In the lab, if we look at HLA-B27, it was tested positive, and CRP, you see it just on the upper level of norm with 5.2 milligram per liter. In this case, we have chronic back pain that started well before age of 45, with inflammatory characteristics associated with uveitis and with HLA-B27 positivity. So it is reasonable to think about spondyloarthritis, but to confirm or to exclude this, we certainly need imaging. In this case, we have MRI of sacroiliac joints, and I give over to Professor Hermann to demonstrate findings on this imaging.
Thank you, Denis. We have a short MRI protocol done over here. In this patient, you can see there are 3 MRI sequences. That's the T1 weighted sequence, the stir sequence, and the gradient echo sequence. The additional semi-axial stir sequence was not performed here due to time considerations, but that would be the recommended protocol of the ASAS group. So we see here in this T1 weighted MRI scan that we start on the dorsal aspect of the joint in the lower slices. We see the spinal canal, the facet joints, and the erector spinous muscle. And we go from the back, from the posterior slices into the joint. So we see here the synovial part of the joint, also a little bit of here. We have the interosseous space over here where you see the bright signal intensity. Also, you can see it here next to the interosseous ligaments. And in this sequence, you already also see there are some fat lesions in the bone marrow, in the posterior aspect of the sacral bone, which we will look at in more detail later. So we are now approaching the central part of the joint, where we see the joint space going from the anterior capsule to the posterior capsule on both sides. And we see there is some irregularity of the joint contour. So there's a suspicion of erosions over here. And then we are advancing further to the anterior part of the joint. And you see there is bone marrow with a little bit of fat content over here, but the cortical border is not enlarged. So there's no pathologic bone sclerosis over here, maybe a little bit only on the very anterior aspect. So there's no suspicion of very severe sclerosis that would lead us to a differential diagnosis of osteitis condensans. Okay, when we take a closer look, it is important to appreciate changes in the joint space. You see there is this black line, which is the cortex of the sacral bone. Then we have this cortical border of the iliac bone, which is not really a smooth line, but frequently, sometimes we see it's rather irregular. And then we have this bright line in between, which is as the same brightness as fat. So we see some fatty components over here in the joint space. And if we go through the joint space itself, for instance, here in this anterior slice, so you see that is the normal cartilage. That is the signal intensity that you would expect the cartilage to have. So that is the normal cartilage. And nicely on the same slice, we have this bright line over here, which is the major finding in this joint space. And this is a finding that we call backfill, or we call it also fat metaplasia in an erosion cavity. So that is what the T1 weighted sequence tells us. When we go further to the stir sequence, we see again that there are bright signal intensity areas in multiple locations. We see some of them in the anterior aspect of the right sacroiliac joint here in the sacral bone. And we see it also on the iliac bone, but only on a very small circumscribed area. We can also appreciate the defects in the cortical border over here. Usually you look at it at these changes on the T1 weighted sequence, or if you have it on the wipe sequence, but you can see it also in the stir sequence. Sometimes the destruction of the cortex, which is called erosion. And on the left side over here, you see also bone marrow edema, both in the iliac bone and in the sacral bone. So there's active sacroiliitis of both joints over here. We can even distinguish some bright signal intensity within the joint space over here, which could be interpreted as an active inflammation in the joint space. Sometimes this is referred to as synovitis, but it also is an earlier sign of backfill, as we have recently found out in a study where we evaluated backfill and correlated these changes with CT. Okay, and then we look at the gradient echo sequence, which we can see here. So this is a sequence which enhances the bone contours. So this is a special sequence. It's an opposed phase sequence. That means water content and fat content equals each other out, which means that these sharp contours are resulting due to accessibility artifacts at the edges of the contour, and you can see nicely these erosions over here. And if we try to compare it with the T1, then you will see that that it is in fact better with this gradient echo sequence to see the erosions. Here you can see the backfill, which is apparently not visible here, but the erosion itself is better visualized on this sequence. And this is the 3 millimeter thickness gradient echo sequence, and you can even improve that appearance if you perform a 1 millimeter wipe sequence. So that's basically what we performed, Denis.
Very good. I think that answered already many questions. So we saw here a case of a patient coming with back pain and on the background of acute anterior uveitis, and this constellation brings already very high pretest probability of more than 60%. But still, the reason sort of 30 to 40% probability that this back pain is explained by other reasons. And that is why, even if there are many clinical indicators that this might be axial spondyloarthritis, it is still worthwhile to look at the presence of active inflammatory and structural changes. And they all were there in this case. So in fact, you saw the full spectrum of changes associated with spondyloarthritis. The active inflammation is demonstrated here, and also the structural changes. So in this case, we don't have, as usual, an X-ray of sacroiliac joints. And in the past, we often said that it is still recommended to do an X-ray first. But if you have an MRI showing these findings, do we need an X-ray? What do you think, Kai?
So I think in these cases, X-ray is not needed. Although that is common practice in many rheumatological centers. We are doing a lot of courses, and people are reporting that they frequently refrain doing X-rays of the pelvis. What you could see on the pelvis X-ray is the symphysis and hip joints as an additional feature. But they were certainly not in question here. Also, you can very easily detect transitional anomalies at the lumbar sacral junction. So if you have a Castel 1 or Castel 2 change, that means you have a fusion of the fifth vertebral body with the sacral bone. That can sometimes be very easily seen on an X-ray. But of course, it can also be seen on an MRI scan, and we are now very much trained in looking at this area here to see if there are any anomalies. So it is not really much that you can see. Of course, if there's degeneration at the lower lumbar disc levels, that can also be depicted on the X-ray, but of course these discs are also shown here, so that's not really a reason to perform an X-ray.
Yeah, I think it's a pragmatic way. So if you're working in a setting where X-ray should be done first before you justify an MRI, I think it's okay. But remember the low sensitivity and specificity of X-rays. So if you are in doubt, if you don't see high-grade sacroiliitis, then you need to go to cross-sectional imaging. There was long discussion in the past couple of years whether MRI structural changes are same changes we can find on X-rays or on CT. And nowadays, I think we have a clarity on this. So with MRI, we can depict the whole spectrum of changes, including those with very high specificity, namely the erosions and backfill, as you saw on T1 and gradient echo sequences. What I found quite remarkable in this case, that the backfill, which is also called as fat metaplasia in the erosion cavity, seems to be quite heterogeneous structures. So it looks like a process and not just one type of lesion, right? So you demonstrated a backfill in a stage with high intensity on stir. So it seems to be relatively fresh granulation tissue with a lot of vessels. And then you see a lot of fatty metaplasia there. And probably at the final stage, you would expect ossification coming in, resulting into the ankylosis. Is it what we understand under backfill now?
Yes, it is indeed a good point that you are raising here, and I think somehow some histological proof should be obtained sooner or later, because together with my colleague Thorsten Dieckhoff, we performed an analysis of these changes, and he divided the changes in the back in the joint space further into 3 different types. And you can see here is the high signal intensity that also shows a little bit of high signal intensity on the T1, but it's largely low signal intensity of the cartilage here. So that is maybe the earliest sign of backfill, where you still have a lot of inflammation over here. And if you perform a CT, then there's already some calcification of that area. And if you compare it to an area where you see here in this anterior part, there is the backfill signal is much brighter, and you see it goes up to the capsule of the joint, and here we have a little bit of bright signal, but the upper part is dark. So this is already more mature, and there's even some type where we have an intermediate step where we have only the stir bright, and T1 is completely dark, which is the first type of backfill. So this is not there's not yet widely accepted to divide backfill further into 3 subtypes, but I think we are only at the beginning understanding what's going on in the joint space. And I think with better MRI image quality on 3 Tesla, or maybe also some 7 Tesla MRI images done for scientific purposes, we might be able to know and learn more about changes going on in the joint space.
Thank you very much. I think that was a very good discussion on this case of axial spondyloarthritis, showing you a full spectrum of changes. We thank you very much for watching this case and these explanations. We wish you great winter holidays, happy New Year, and we would be happy to have a next case discussion at the beginning of next year.
See you next time. Bye-bye.